So last year's ESMO was full of PARP maintenance, and this year ESMO 2020 was very similar. We saw some follow-up data around the PRIMA study, which was looking at the use of Niraparib as frontline maintenance in ovarian cancer. Importantly, what we saw was, in addition to providing the progression-free survival benefit that has been previously presented and yielded an FDA approval, we also saw improvement in quality of life. And so that's really important when we look at patient-reported outcomes to understand the impact of these targeted agents on how a patient is doing on a day-to-day basis. And reassuringly, what they were able to show was that Niraparib did not have a negative impact, and it appeared that patients did better when they were treated with Niraparib as far as quality of life was concerned. I mean, I think that it's super exciting to see that we can get survival impact or progression-free survival impact with the use of targeted therapies. I think next steps really, we're not seeing a universal impact, right? So we've seen over and over again that the patients that get the biggest bang for their buck with Niraparib or any PARP inhibitor maintenance are those patients that have a BRCA mutation. We do see benefit, but maybe not as profound in those patients that have a homologous recombination deficient tumor. And really, the population for whom we really need to continue our work for is the group that have tumors that are homologous recombination proficient. So those tumors that don't have a biomarker. We can see benefit with PARP alone, but it's just not as profound as what we see for those patients that do have a biomarker. And so that's really where I think the work is moving forward, is to really work on that population and make sure that they get as much benefit as those patients that have those aberrations. So in addition to the exploration of PARP inhibition in ovarian cancer, we saw a really important study come out, which was the Imagine 50 study. Now, this study was in a similar population. So it was a population that had upfront advanced stage ovarian cancer, and they were randomized between standard of care chemotherapy with bevacizumab, an anti-angiogenic, or the same regimen plus atezolizumab, which is a PD-L1 inhibitor. And so the question here was, does adding an immune oncology agent both to chemotherapy as well as to maintenance help yield a progression-free survival benefit? And unfortunately, what we found was in an all-comers population, there was no additional benefit to kind of adding that immune oncology agent to the standard of care with chemotherapy and bevacizumab. However, they did do some interesting planned analyses. You always have to be careful with these because it wasn't the upfront or the primary endpoint, but they did see that potentially in a patient population whose tumors have PD-L1 expression, that there may be a benefit to the addition of that immune oncology agent to the atezolizumab. So it'll be interesting moving forward as we try to really parse out which population may benefit the most for the addition of these agents.